At this point, I would like to introduce Dr. Robert Lawrence, who is going to be presenting some information on this topic. And the other speakers and the participants, we hope are going to have a very interactive discussion on the topic. Dr. Lawrence is a faculty member of the Florida Caribbean AIDS Education and Training Center. He's been a faculty member for several years with us. He's a clinical professor of medicine in the Department of Pediatric Immunology and Infectious Diseases at the University of Florida in Gainesville. I had the pleasure of working with him closely there when I was at the University of Florida in Gainesville for several years. I actually painted my nails gator orange and blue for our game that was taking place last week, our basketball game. Unfortunately, my orange and blue fingernails and toenails didn't do anything for us. Sorry about that. Dr. Lawrence has over 25 years of experience in pediatric HIV and has participated in research with the Pediatric AIDS Clinical Trials Group. He provides direct clinical HIV care for infants, children, adolescents, and young adults in Gainesville and surrounding counties, as well as at satellite clinics in Tallahassee, Panama City, and Pensacola. So without further ado, I'm going to introduce Dr. Lawrence.
Thank you very much, Joanne. Welcome, everybody. I'm happy to get to this session today. I know we've been working with a number of members of the CPT group, Brenda Toon, Teresa Morris, and Dr. Alexander, and we're hoping that this session today will continue that dialogue back and forth and really get to some of the issues and concerns that you all are interested in relative to HIV post-exposure prophylaxis. So feel free to raise your hand where there's a marker up here where you can do that electronically. You can also type in a question if you would like, and we will try to answer those as we're going along. We will be leaving time at the end of the session as well to actually have some discussion, and I have some suggestions for issues for the future, but we're happy to hear any of your concerns and thoughts. So let's go ahead and get started. These are the specific objectives for today. Hopefully we can be able to summarize the steps needed for assessment of risk of HIV in children and adolescents due to non-occupational exposure, most obviously sexual abuse or other events like that. Additionally, we want to be able to discuss the decision-making relative to initiating HIV post-exposure prophylaxis. And then finally, hopefully, we all will be able to create a plan of action for the potentially HIV-exposed individual and the important follow-up that will be required for that. This is some of what we're going to go through during the session in terms of covering different topics as we go along, just so you see that. We can start off with a definition of, quote, non-occupational HIV exposure. That's the terminology that's used nationally, but it specifically relates to exposure to blood and or body fluids in any, quote, non-occupational setting, and that can include human bites, needle stick injuries outside in the community, sports-related events. And probably most importantly for you all, can include chronic sexual abuse or an acute single time frame sexual exposure via any route, vaginal, oral, or rectal. Here are just some scenarios, and we're just going to look at these quickly. We will come back to these at the end to talk about them a little bit more, including that these are somewhat standardized or stylized, and you all may have other specific information about cases that are similar, and you may have specific questions because the exact characteristics of a specific scenario for you all might be slightly different, and we'll be happy to talk about those when we get to it later. So just the single-time sexual exposure in terms of one event. This is a separate one in a male, apparently multiple assailants. It's uncertain, and so a little bit different, each of those. This is for a 16-year-old who has sex with a friend, a boy, a boyfriend, someone she knows from school, and mother is involved in this scenario. And it may be that this doesn't occur so often at CPT. This might be a more common event at emergency rooms. Here's another one with a teenage male, and again, a single exposure with the question of, is this a significant exposure and what's the risk? Case number 5 is about a 10-year-old and needle stick injury with some specific features. And the last case is about a 6-year-old with history of a bite. Not spelled right, but a bite anyhow. So we're going to go through a little bit of background information for post-exposure prophylaxis. And part of that is just so that you all can see what kind of data is behind the actual treatment proposals for post-exposure prophylaxis, and what are some of the important variables that we do have actual data and measures for. So first of all, in animal studies, it's very clear that there's a very narrow window in which to intervene. And the idea is in these McKay studies, the simian immune virus RNA is found very quickly in subepithelial cells, in adjacent lymph nodes, and in blood within a very short period of time after that exposure. And other animal studies revealed mixed results relative to that narrow window in terms of the exact timing. But in those studies, it was very clear that a longer exposure to ARVs, and they thought 28 days was the best estimate of prolonged exposure to ARVs, as in PEP, was still not 100% protective. These are observational studies, and you will find most of these quoted in the original publications by the CDC in the MMWR. First, from Brazil, in men who have sex with men with a high-risk incidence cohort, men who actually took the post-exposure prophylaxis, their risk of seroconversion was 0.7 per 100 person years. In men who did not take the PEP protocol or ARV medications, the rate was 4.1 per 100 person years. In another study with post-sexual assault in Brazil, specifically with women being treated in less than 72 hours, they had used 2 different regimens, a 2-drug regimen with zidovudine and 3-TC, or a zidovudine, 3-TC, or indinavir. And the women who had received PEP had a 0 conversion rate, and women not receiving PEP had a 4 out of 145 of those individuals seroconverted. In another post-sexual assault study from South Africa, these were rape survivors, and they were followed for 6 weeks. There was 1 seroconverter out of 480. They did not comment on the actual number of individuals who received PEP overall in that study. The individual who seroconverted started their post-exposure prophylaxis later than is recommended. Additional observation studies include some of these. First, from San Francisco, in 401 individuals with a sexual or an intravenous drug exposure who completed 28 days of antiretroviral medications, or they interrupted that course of post-exposure prophylaxis or did not receive it at all. In that 401 individuals, there were no seroconversions. That simply speaks to the fact that which we already know, that the rate of seroconversion may be low given the specifics, and certainly in this scenario, the rate of seroconversion was, quote, very low. In British Columbia, also, it was noted that there were no seroconversions in 590 people who completed post-exposure prophylaxis. And in different database registries from Australia, France, Switzerland, and the United States, a compilation of approximately 2,000 cases with a variety of different types of sexual exposures. They specifically looked at the 350 individuals who had post-exposure prophylaxis treatment in the situation where they really felt the suspected source case was HIV positive. And in that, again, we had no seroconversion in 350 individuals. Those were treated individuals. And then relative to the one area where we clearly know that prophylaxis is effective, and that is the prevention of perinatal HIV transmission, there is some data from those studies and various studies that support the use of post-exposure prophylaxis. First of all, in general, historical controls, if there are no interventions in terms of trying to prevent HIV transmission from mother to infant, then the risk of transmission is 20 to 30% in all comers. That does not include the additional risk for breastfeeding. And so in several different studies, we see what happened with, in this case, a single dose of nevirapine given postpartum just to the infant. So the infant's exposed throughout presumably much of pregnancy, but also significantly at the time of delivery, where we believe 2/3 of transmission occurs in the natural history of perinatal HIV transmission. That single dose decreased the transmission rate to 12% if we compare it to the original historical control. And in a second component of that study, they used both nevirapine and 1 week of zidovudine for the infant. And in that combination use of antiretroviral medications, then transmission rate was 7.7%. Comparatively, in South Africa, they used a regimen of zidovudine and 3-TC, or a regimen of, that was intrapartum, and then 1 week postpartum. So in that peripartum exposure, intervention led to a decrease to 9.3%. Separately, they also noted a single dose of nevirapine to the mother before delivery and a single dose of nevirapine to the infant within 72 hours led to an apparent decrease in transmission to 12%, again, compared to historical controls. And then again in Uganda, we see single dose nevirapine to the mother before delivery and 1 dose to the infant led to a transmission rate of 13%, and again, intrapartum zidovudine plus 1 week of zidovudine to the infant led to a transmission rate of 25%, certainly within the realm of what was obtained with no intervention whatsoever. And then specifically from the United States, again, the historical control rate was 20 to 30% transmission. In New York, when zidovudine monotherapy was given to the mother during delivery, that's actually given IV through the whole time of labor, and to the infant beginning within 72 hours, that reduced transmission by 50% in a study published by Wade et al. And then in a separate study group, the PAC study, zidovudine was given to the infants within 24 hours of birth when mothers had not received either antepartum or intrapartum antiretroviral therapy. And that also decreased HIV transmission, and in this case, by 48%. And then finally, some considerations for cost effectiveness, which have been published. In the U.S., if a person is known to be HIV positive, i.e. the reported source or alleged source, unprotected receptal anal sex with bisexual or homosexual encounters with unknown serostatus, they felt that treatment with PEP was cost effective in at least one analysis that has been performed. In France, there were a couple of different analyses, and they noted that it was cost effective in the situation where there was unprotected receptive anal intercourse with a known HIV positive, or a partner that may have been at, quote, higher risk for HIV. There was no evidence of cost effectiveness for PEP for penile vaginal sex, insertive anal, meaning the partner who is performing the insertion, and then finally other exposures. And then from Canada, they analyzed whether people were receiving PEP appropriately, and they found that over half of the people received post-exposure prophylaxis not as indicated by the guidelines, and they didn't comment specifically on cost effectiveness. This is a slide showing us a comparison, if you will, of the estimated per act risk of acquisition of HIV. And you can see that this comes from a number.
Lawrence, we're not hearing you speak anymore.
I'm sorry.
There you are.
Sorry, I didn't move much. Is that better?
Yeah, we can hear you now. It must have muted, but just go ahead and start at the beginning of the slide.
Sure. So this slide reports estimated per act risks for acquisition of HIV, and it comes from, it's a compilation from a number of different articles listed here for your reference, and it's really meant to just compare the relative risks. In the previous slides, we were looking at considerations for insertive anal sex. We saw about penile vaginal, and in this case, additionally oral. Here was receptive anal intercourse, and you can see that there's at least based on the data that was published in these papers, there's a clear difference in risk. This is data that I'm going to presume that most of you all know better than I do in terms of the number of sexual offenses that occur within Florida and the frequency with which they occur, and notably that at least 25% of those involve women, and the probably a significant exposure to body fluids. And then these are known cofactors that do increase the risk of HIV transmission. They include that the perpetrator or alleged perpetrator is HIV positive, that the viral load, if it's higher in that individual, then the risk of transmission is greater. The presence of other sexually transmitted infections in either of the individuals involved, the amount of trauma can lead to increased risk of transmission, actual ejaculation by the alleged perpetrator, and then multiple perpetrators or multiple penetrations. And then sexual assault, alleged perpetrators or actual perpetrators, the risk of being HIV positive. These are some of the variables that we do recognize as being related to that increased risk of being HIV positive. Certainly in pediatrics, perhaps not all of these are applicable, but they may be certainly in the situation of rape. And then finally, additional risk factors specifically related to needle sticks. Obviously, the source for whom the needle was used, if they're HIV positive, the size of the needle is important. Small bore is a significantly less risk than a large bore needle that conceivably could have blood or dried blood within its opening or canal. The presence of blood, meaning the blood is actually evident there, and then how long it can live. At room temperatures, it actually, at least 8% of samples in different tests were still positive on day 21. When you go to higher temperatures, potentially ambient temperatures in Florida, that viability may drop off in a much quicker rate. And then finally, for needle sticks, obviously skin penetration, and there's always a question about, quote, whether the prevalence of HIV in the community is a factor that we should, in reality, even consider, because we probably have little or no information about the potential source. And relative to human bites, here are some of the risk factors that we think are important. When the skin is not broken, that we should think of that as negligible risk. When saliva containing visual blood is involved in the incident, and if the skin is broken, and then clearly the body fluid, or in this case blood exposure to any of the individuals involved. So going to move a little bit into the actual decision making, and we're going to go through some of these considerations, and then we will look at them in a couple different ways over the next several slides. So first and foremost is always trying to assess the degree of exposure. What's meant by degree here? Simply that it is actually an exposure to body fluids, and that those body fluids did come in contact with mucous membrane surfaces, or in some cases even the skin of the individual that you're meeting with or talking with about the potential risk. We should think about offering HIV PEP to patients with this known or presumed to be HIV negative individual who now has a significant exposure that we feel has put them at risk. Our next step should actually be to discuss the risks and benefits of taking antiretroviral medications, talking about PEP and what it means and what are the potential benefits for them, but also talking about the risks. We should reinforce the importance of adherence for the full 28 days. And part of that is also assessing the individual's willingness to take post-exposure prophylaxis, and in fact, making some assessment of their ability or likelihood to actually complete that whole regimen. We should go over specific common adverse effects of the antiretroviral medications. This is a short list, and we'll have expanded information on this later. And then that acceptance of taking PEP should be voluntary. I think that's probably pretty obvious to most pediatricians or people who are involved with children and families and children, but it's never hurts to emphasize it. And then finally, emphasizing the importance of follow-up. Here I list 6 months, but later I will note some differences of opinion about that. And then these are probably the most important considerations in assessment, and these come from the update in July of 2013 by the New York State Department of Health for their guidelines for HIV prophylaxis for victims of sexual assault. And they emphasize, and the CDC supports this emphasis, simply, was this a significant exposure? Next, do we have information on the alleged assailant, particularly about their HIV status? And is the victim ready and willing to complete the post-exposure prophylaxis? They feel that if you boil your assessment down to those 3 questions and you effectively answer those and address those, that you can effectively assess the need for post-exposure prophylaxis and offer it in situations where it's most likely to be useful. The other 2 things that they emphasize are that decision-making should not be influenced by the geographic location. So it doesn't matter what the apparent HIV prevalence is in the community. That should not necessarily be a factor. That's particularly true for needle sticks, particularly of needle sticks found in parks or different areas around a specific locale. And then also they emphasize that assumptions about the alleged assailant's HIV status or their risk should not be influencing the PEP decision. Why? Because those are simply assumptions. They don't really tell us information about the actual situation. And if we think that there has been a significant exposure and we think the individual can complete a regimen, then we should be offering post-exposure prophylaxis. this is a great reference. This one is actually not too long. It's I think 10 or 11 pages, and it's a great reference to have available to you if you have other questions or you're looking to see how the New York State has tried to formulate their statewide guidelines. So, post-exposure prophylaxis, that little n just means non-occupational exposure. PEP is recommended when mucosal surfaces, vagina, penis, anus, or mouth, come in direct contact with the alleged perpetrator's semen, blood, or vaginal fluids, with or without visible injury, with or without tissue damage, and with or without the evidence of blood. It's just emphasizing again, making sure that we can think about this carefully. It looks like this slide had a little problem with formatting here, but this is meant to talk about post-exposure algorithm after sexual assault. And this is certainly an algorithm that has been recommended for a number of years in terms of going through different steps to try to clarify your assessment. So the first one is always, did a significant exposure occur? And if the answer is no, then post-exposure prophylaxis is not indicated, and in fact, follow-up related to HIV is not indicated. There may be other follow-up that you at CPT would consider essential, even in this situation, but related to HIV, follow-up is not necessary. If there was a significant exposure, was that exposure an isolated event, i.e., if it was not, that there was actually repeated exposures over time, this might be consistent with chronic sexual abuse of a young child or young adolescent. And so in that scenario, post-exposure prophylaxis is not indicated, but follow-up related to the HIV testing and their status clearly is, because if there have been multiple exposures over time, then the timing of when that infection or transmission occurs may have been months ago, or it may have only occurred recently, and so needing to follow out for an appropriate time period. If that exposure was an isolated event, then is the person presenting within 36 to 72 hours? The reason for that is you want to initiate PEP early on. We know that the window is narrow to provide effective post-exposure prophylaxis. And in general, when you're out beyond 72 hours, the likelihood that post-exposure prophylaxis could be effective decreases significantly. If the answer is no, now they're presenting after 72 hours, PEP is generally not indicated, but testing and follow-up are. If they presented early on, and the next question might be, is the source or the alleged perpetrator available to be tested? In most scenarios, they are not, and so we can't go to this side. They are not, and so we have to go in this direction. I apologize. And we have to consider no, we can't assess them. We'll have no additional information about the alleged perpetrator and the HIV risk. But we know that there's a significant exposure, then we should consider PEP and initiating PEP. If the source is, quote, not high risk, then we should consider recommending no post-exposure prophylaxis, but still consider follow-up. And here, there obviously is a fair amount of uncertainty. If the source is available and is tested by rapid testing, then if the results are positive, then you would initiate PEP. If the results are negative, then no PEP is indicated. However, if you're at this stage and you actually think that there was a significant exposure, then beginning post-exposure prophylaxis or recommending it would be very appropriate. And then later on, waiting for the results to then discontinue PEP, particularly if we remember this very important narrow window period, including that, in fact, the recommendations are to ideally start post-exposure prophylaxis within 2 hours of exposure. obviously that clearly depends on the timing of when the person presents to medical care. Is that okay for everybody? I know it gets a little complicated, and obviously it's probably sometimes easier if you go through it yourself, thinking of each of the steps and clarifying in your own mind, okay, what might I do next? Here are situations where PEP is clearly not recommended, so just to reinforce these, when we don't know we know the status of the alleged perpetrator, and that in fact is negative. The sexual assaults occurred with the use of a condom, that other objects are related to the abuse or potential for exposure, and it does not involve body fluids. Ejaculation on intact skin, PEP is not recommended. Other kinds of sexual activity where there is not real body fluid exposure, oral-to-oral contact without mucosal damage, and human bites not involving blood. Each of these in some way addresses the issue of was this a significant exposure or not. And then I'm just repeating this slide here again to make the emphasis simply that has a significant exposure occurred, what information is available about the alleged assailant and their HIV status, and is the victim ready and willing and able to complete the post-exposure prophylaxis. With those previous slides starting to get a little bit complicated, I wanted to remind us that these are the three main and most important steps in assessment for HIV post-exposure prophylaxis. Here's some of the recommended monitoring after exposure, and these are recommendations from both the CDC and the New York State Department of Health. There are some slightly different recommendations, and the asterisk, if you will, A, noted in these places is where the CDC recommends the testing at these intervals, and New York State Department of Health does not. So baseline, you're trying to do assessment for all of these potentially, particularly with the issue of other risk factors for other sexually transmitted infections, as well as for the risk of pregnancy. This is pertinent for your post-exposure prophylaxis and use of antiretroviral medications in order to monitor for potential toxicity of those medications. And then here would just be follow-up clinic visits, contact back to medical care with specific assessment for HIV occurring at baseline, 4 to 6 weeks, 3 months. And here, the difference between the New York State Department of Health recommendations and CDC is that New York State is using testing that includes both antigen and antibody testing. And so they feel with the newest 4th generation testing that the testing is so effective that we would not miss any cases. And so data from the 3-month testing is adequate in terms of completing your assessment for HIV. Okay? And then now we're going to go through a number of the PEP regimens. Again, with this, for individuals who do not routinely use antiretroviral medications, this may become a little bit confusing, but we're going to try to make a couple of very specific and clear recommendations to you all. So first of all, the preferred regimen for PEP is now the use of tenofovir, emtricitabine, and raltegravir. And the reasons for this is a very effective regimen. It's a simplified regimen in that these two medications come in one pill, and so the number of pills or the pill burden is clearly decreased, and all 3 of these medications have a very good safety or side effect profile. And so that's why this is the current preferred regimen for post-exposure prophylaxis. When we talk about children, between the ages of 2 and 12. This also is the same regimen. However, based on their weight, you would have to choose specific dosing based on weight, and there are set tables for using that. As always in children, the weight-based dosing may make it a little bit more complicated, simply in the sense that you have to stop and do those calculations and recheck those calculations. And so this is a table just for raltegravir dosing as one of the 3 preferred drugs for the regimen. I have listed some of the potential side effects here for raltegravir, but again, raltegravir in fact is one of the better medications in terms of its side effect and safety profile. This reference down here is for antiretroviral therapy use in children and adolescents, and so it serves as the resource for these dosing tables. This is a dosing table by weight with using either powder or tablets, and the use of powder here is for those children who are unable to swallow tablets. In general, that is most commonly going to be children under the age of 5, 6, or 7, unless they've had, quote, previous experience or practice. Until they get to that age, they're very unlikely to be very good pill swallowers, and so considering powder rather than tablets in those younger children is very appropriate. Same is true for M-tricidabine. The dosing is weight-based, and there is an oral solution and a capsule. And again, that should, in addition to considering weight, you should be considering the ability of that individual, based on their age, and/or previous history, to effectively take either the oral solution or the capsule. This lists alternative post-exposure prophylaxis regimens, and particularly for children in general less than 12 years of age. In both of these situations, if you're going to consider one of these alternate regimens, because of the different dosing issues in both cases, it's recommended that you would consult someone who's an expert in either post-exposure prophylaxis, and particularly with post-exposure prophylaxis in children, or an individual who's a specialist in pediatric HIV, so to help facilitate that weight-based dosing. And then these are the same alternate regimens, but for adolescents over 12 years of age and who are Tanner 4 and are over 40 kilograms in weight. So most commonly those older adolescents, and this might mirror what an alternate regimen might be in an adult in certain situations. Here are some of the potential adverse effects for each of the drugs that we have listed above. Lamivudine is listed here in terms of some of those potential adverse effects. Here's M-tricidabine, and here's tenofovir, 2 of the drugs that are on the preferred regimen. And then here's zidovudine as well. And these are potential adverse effects of some of the other drugs. These happen to be all protease inhibitors. And so darunavir and atazanavir are in the alternative regimens. Lopinavir is a drug that was used and continues to be used significantly in children, and so we have a lot of experience with it. And in some certain instances, this may be the regimen that, this might be a protease inhibitor that would be selected for post-exposure prophylaxis. Ritonavir is a drug which is used to boost the levels of the other protease inhibitors. In this case, the ritonavir is already included in the preparation of lopinavir, ritonavir as a combination formulation. So now we're back to the scenarios, and so I want to go through these. I've been doing most of the talking, so I really want to slow down, and I really want you all to feel like, okay, I have a thought about this, or I have a scenario that's similar, but here's another consideration that I have. And so I really want to make sure that all the participants feel like, no, I can jump in and say something. And obviously I have both Larry Friedman and Sania Mahmoudi here to help me as well to comment on these scenarios. So the first scenario is a 14-year-old female who was sexually assaulted by her uncle on one occasion. There was vaginal penetration without a condom and with ejaculation. The HIV status of the uncle is unknown, and the mother says the uncle has sex with men. So in red, you see, oh, test the uncle. There are potentially some issues and problems with doing that or actually achieving that. Ideally, you would then base your decision-making on those test results. And then if no testing was obtained or is obtainable, you might still recommend post-exposure prophylaxis. So anybody have a thought about that or an opinion? Why are we recommending post-exposure prophylaxis based on the information that I reinforced for you previously? Anybody have a particular thought about that? Tania, what's the most important fact about that case for you?
Well, you know, we have vaginal penetration with contact with semen because of ejaculation, so that puts the patient at risk, as well as the HIV status of the uncle is unknown. So both together puts it a high risk situation.
High risk, significant exposure.
Yeah, and the uncle had, you know, sex with men, so, you know, just the history of the uncle too is.
And without condom use, he's even more at risk, that uncle. And so besides the HIV testing, there certainly should be a pregnancy test on the female, as well as tests for syphilis, gonorrhea, chlamydia, etc.
I know that CPT has specific guidelines for doing that testing and that follow-up. We're mentioning it just to be complete. Is there anything in this situation that we either haven't considered, or is there anything else in this situation that perhaps we should or shouldn't consider? Are there any other variables to this case?
You know, one thing comes to my mind is that this child is at risk, and she's being, so there's issue of her safety and who is taking care of her and keeping her safe.
Mm-hmm. Yep. Again, I think that's an arena where the providers in the different child protection teams across the state are pretty well versed, and but it's clearly a question that probably for each one of us comes to mind for sure.
But one of the things that we would certainly do is we'd find out if this is their only sexual experience, because we would not assume a 14-year-old this is her first time.
Okay, should that influence your decision making about PEP? Or does it simply reinforce what you might do for testing and follow-up?
More the latter.
Mm-hmm. Yep. In the red here, in the printed red recommendations, I didn't include that we actually did an assessment of this young woman's interest, intention, and probably ability to take the post-exposure prophylaxis. And so, Dr. Alexander, as you were suggesting, there's clearly more information about the family situation and this young woman's situation that might help us. If this young woman was homeless, that might make us doubt the likelihood of her actually completing post-exposure prophylaxis. If she was in a different scenario in a home with family support and other people who would reinforce the importance of this and perhaps help her complete the whole regimen, then the likelihood of success of completing the PEP regimen certainly would appear to be higher in the second scenario. The other thing that New York State in their guidelines from July of 2013 highlight and remind us is that we probably shouldn't consider what the mother says about the uncle. Although we all think probably the same thing, okay, the risk that this man could be infected is higher, that's an assumption. It's potentially based on hearsay, and so they actually recommend that we not consider pieces of information like that. And we should go back to, was this simply a significant exposure, and do we really think that the victim here, with their life situation and the support that they have, can they complete the PEP regimen? Other comments or thoughts about that? Anybody else have similar cases but twists to them, or other important variables that we haven't talked about for this particular case?
Well, from a legal perspective, I'm putting this uncle in jail, arresting him right away. Would he be tested right away, or because you want to start PEP prophylaxis within 36 to 72 hours, not more than that?
That's a good question. Dr. Alexander, what's your experience here in Florida? How often do you think that happens, and how effectively are we able to obtain testing in the legal system in Florida?
I think it's variable, but I would say that probably most of the time we don't do a good job.
Mm-hmm. New York State actually has a separate procedure and guidelines for the testing of alleged assailants and guidelines to judges, as well as guidelines to medical professionals in terms of at least being able to know what's the likelihood that they will or won't be able to obtain testing results in a particular situation. So New York State has a separate document that from their guidelines for PEP, they have a link to their guidelines from the I'm going to say legal perspective in New York State. So they have some additional guidelines specifically addressing that issue.
That'd be great.
Yeah, it's listed as a link in that publication from July 2013. Should we go on to the second case? This is a 17-year-old male sexually assaulted at a party by an unknown number of assailants. There clearly was rectal and oral penetration with ejaculation and no use of condoms. And part of that information is available simply because the physical evidence for the individual shows trauma and shows dried secretions. The victim reports while he was at the party seeing IV drug use, and one man he heard told others that he had been in jail. In this case, pretty significant exposure. The person themselves is very concerned and worried about this, and is clearly has come asking about sexually transmitted infections and come asking about what he can do. And so in this scenario, post-exposure prophylaxis is clearly indicated, and including all of the appropriate testing and monitoring. Are there things about this case that strike anybody or that people have other questions about?
Well, I can just say that this is a real case that we see. We have 17-year-old boys who do find themselves HIV infected because of such activity or criminal events that have taken place. So this is something that we really do need to be aware of.
Yeah, these are not cases that I've made up. These are cases of individuals who I've seen and been involved in decision making about their post-exposure prophylaxis. And I'm sure, I mean, based on the simple descriptions here, I'm sure that these are cases that are pretty common to or pretty well known to the CPT teams. Is that true, Dr. Alexander, in terms of having males as well as females, and what's the difference at this juncture? Do you think you see more teenage females or more males?
All females by far. You know, I was just thinking, we were just talking, whether he was sexually assaulted or voluntary really isn't going to change anything.
Great, absolutely. And it probably would. Go ahead, Larry.
No, I was just going to say there's a question from the chat line. Ms. Fleming wanted to know when the assault occurred, and obviously that would have an impact on the recommendation of the use of NPEP. If the assault had been 2 months ago, obviously our approach would be a little bit different, but if it were last night, we would want to get the NPEP started as quickly as we could.
Great question. Thanks for re-emphasizing that as one of the important considerations for the use of PEP. That's great.
And then Ms. Sanchez is asking if there would be some sort of support service that would assist the young man to take his medication, and who would cover the cost of the medication.
Yep. Cost is an issue that we haven't talked about, but absolutely becomes a big issue here in Florida, including just managing our healthcare systems and knowing how, what the options are, accessing victims assistance services and how one can do that. And in this case, if there isn't an adult supporting this young man and or helping him navigating those medical systems or even the victim's assistance program could be difficult for this 17-year-old.
And covering the cost of the medication is really variable in my experience. There are some insurance companies that actually cover it, but the medications are something like $1,000 a month for the month's supply of each, and so it could be very cost prohibitive without some assistance. Most of the state, I don't think, has that in place yet, although certain health department units might have some other grant or research project or some other way to supply the PEP med.
From the CPT team side, do you have other comments about that? Because I know you all deal with these individual cases and deal with the individual and all the trauma that's occurred to them on many different levels, and then to have this issue of finance and follow-up be a difficult one. Do you have comments about that for you all?
Well, from a CPT point of view, we're going to, we're going to end up passing this along to a treatment provider, and that is a concern of ours. Is who is going to pick this up, and to that end, obviously we're in some discussions with Department of Health, to see to what extent the health departments can help out on that. but we certainly don't have a final answer.
Yep. New York State does have a starter pack, a 7-day starter pack, which they have been instituting in various sites, emergency rooms, and also their child protection teams, trying to have that first 7 days be less of an issue, with reinforcing exactly what you said, Dr. Alexander, and that is in that 7 days, making sure that they're taking the post-exposure prophylaxis, and then making sure that they have continued follow-up with a provider who's going to manage the medications and manage the potential side effects.
You know, I know for patients that get referred to our clinic, automatically the patient is assigned a medical case manager, and this case manager would make sure that there's a process in place or a plan in place for the patient to take their medications, either find a support system for the patient or giving them calendars, pagers to remind them to take their medicine, and there's a lot of other things, home visits, you know, bringing the patient frequently to the clinic. So there are some, venues for that. However, for covering the cost of the medications, that's the hardest one that we find. If they have insurance, we always have copay cards that we give them so they don't have to pay for the copay. And these are provided by all the pharmaceutical agent drug companies. But if they don't, like Medicaid patients, it's sometimes hard to find who's going to cover the medications for these patients.
Yeah, I've only been successful on one occasion to have victims assistance services actually release money in a expedient time period to really assist the patient after the first 72 hours of having been given some post-exposure prophylaxis to start. The Victims Assistance Program actually released money to continue the payment, but that's one out of probably a couple dozen.
And
so
assistance programs also, like through pharmaceutical companies, and they can release the drug. You can have it, come. It really depends on the company. Some of them expedite it. You can get it within 24 hours, but some of them takes 4 or 5 days, and that's not good.
Yep. That's Sania, that sounds like something that perhaps we should talk about a little bit more. We may be able to, even from the AETC perspective, approach perhaps the companies that provide the medications in the preferred regimen, and then really sort of almost contract with them about this, and then perhaps to devise a system of ready access to that others could utilize here in Florida. And so that might be something to consider. And I'm sure that that's something that Dr. Beal, the head of our Florida Caribbean AETC, he and I have talked about before, and I'm sure he'd be interested in doing that. So let's consider that, and let's think about making some progress on that. Let's go on to our next one. This is a 16-year-old female who reports having vaginal sex without a condom, with her consent, with her 17-year-old date, quote, a boy she knows from school. Mother wants her treated for STDs, HIV, and with the morning after pill. The daughter actually comments that this is the third time that they've had sex. In this case, we would probably not recommend post-exposure prophylaxis. We would recommend STD testing for both individuals. We would discuss risks and benefits of morning after pill, and we would discuss standard birth control methods and safer sex. I don't know if this is a scenario that you would see at CPT. Obviously, there are about 14 other social considerations. One, the mother and the daughter, and whether there are differences of opinion about how to proceed, or what they each would want to do. But is this a scenario that you all are involved in at CPT, or this is something that you try to have addressed by perhaps a primary medical provider?
Well, this is, first of all, the 16-year-old having sex with a 17-year-old is legal in the state of Florida. So we wouldn't typically see this for CPT because it's consensual and that 16 and 17-year-olds can have sex with somebody under 24. So from that point of view, yeah, there's no legal issue at stake here. But if we change the scenario and made it a 15-year-old girl that had a boyfriend like this, that would be a scenario we see a lot. And we would do STDs. We would, if it was just shortly after we got to him, we would do the morning after pill, and then we'd do testing.
Mm-hmm. Is there a specific time frame outside of which you don't use the morning after pill? And I'm asking because I don't know.
Yeah, certainly no more than 72 hours.
Mm-hmm. Thank you.
Yeah, really kind of like 24 or 48 hours, but
Mm-hmm.
we'd consider it, sure.
Nope.
And you're exactly right. We'd also say if you're going to keep doing it, you got to, come up with an alternative other than coming test. But if it's a 15-year-old, there is a legal issue. What will probably happen, though, is it will not be a prosecuted issue, even if the mother's all upset. The prosecutors tend not to go after 15 and 17-year-olds having sex, even though that would be illegal. They've got murder trials and other things to do, and so it'd be tried to dealt with in some other way.
Other comments or other thoughts about that case before we move on? So case number 4, a 17-year-old male who, after fighting with his mother about his, quote, sexual preference or preferences, has receptive anal sex without a condom with a, quote, older man who the young man knows to have sex with men and boys, and the older man's HIV status is unknown. For me, this is a significant exposure. We would recommend post-exposure prophylaxis and standard testing and monitoring, and obviously discuss safer sex with the young man. I think the issue of assessment of this young man's willingness and ability to take the post-exposure prophylaxis is certainly something that I would spend a little more time on in terms of really trying to make sure that if I could, with me recommending it, that I was figuring out how to support him and how to make sure that he completed the whole course.
So from a CPT point of view, we'd want to know, how long's it been?
Yep, great.
And then, as always, and then the other thing is the older man's how old? Because depending on age, it could be illegal. If he's 24 or older, it's illegal.
Mm-hmm.
And then just to complicate things, if this is in Estonia, the age of consent is 14. So it all depends on where you live.
I'm sorry, where is that?
Estonia, Eastern Europe. Most of Europe is 50 years old. So it varies depending on the part of the world you're in. And in Georgia, you got to be 18 by and large.
Yep. Sorry, I was trying to think of Estonia, Florida, and where that was.
Well, I don't know.
Larry?
Yeah, I was just going to say, unfortunately, this is also a very common sort of scenario for new onset of HIV infection, that frequently a young guy, a teenager, has communication of the HIV from an older male, very often older than 24, and the teenagers rarely identify that older male so that any kind of case can be brought for it.
Absolutely.
They
Okay.
identify these older people as their friends, you know, because they take them shopping and they take care of them, and
That certainly raises the issue of, quote, clarifying also that this was a single one-time exposure versus someone who has repeated exposures in scenarios, as you just described, where you probably wouldn't recommend post-exposure prophylaxis. So that highlights another aspect to this, that at least in this case, it's implied that this is a single event. So, good. Going on, case number 5, 10-year-old male playing in a local park picks up a needle and syringe. He pricks his finger with it, leaving a small pinpoint dot. This was an insulin syringe with a small gauge needle. There is no visible blood seen on the needle. And I guess, weather report says that the park is in Florida. It's during August, and the temperatures have been over 90 for the last 3 weeks. In this case, we would not recommend post-exposure prophylaxis. The main reasons: small bore needle, small syringe, no obvious blood. We might or might not consider the temperature as being a significant issue relative to the viability of virus over a period of time. And the main reason is because we honestly don't know how long the syringe has been sitting there. So,
however, if this happened, we had a case like that where, you know, the young man pricked his finger with a TB syringe needle. Actually, it's an insulin syringe that the grandmother used, and the grandmother was HIV positive. So we had to put him on PrEP or PEP.
Yeah, and that I think that does change the issue a little bit, in the sense that it's what you're really saying, Sini, is that was a significant exposure. Now the estimate of risk relative to the size of the needle, the bore, and whether there was blood might alter our thinking about that. I guess the other issue is if you knew, you know, if the grandmother had left the needle on the kitchen table and the young person came by 5 minutes later and did it, then you might at least consider, okay, the viability of the virus here is potentially still very high, and so even if there's a small amount there, we want to try to protect this young person.
Right.
Other comments or other thoughts?
Yeah, we have a question from Sashi. How long does the HIV virus remain alive outside of the host? And I think
Go ahead.
And in the previous slide you mentioned, you just mentioned percentage.
I did, and I mentioned it. Both of those pieces of information were about blood on firm surfaces. There's a lot of highly variable data when you talk about leaving in a bloody rag, tissues, other materials or things like that that could potentially still harbor virus. The implication in the early studies was that with those cloth or paper or products like that, that the virus actually had longer viability than it did on hard surfaces or a syringe or a needle. But we don't have exact information for that, and so I was giving you what we have as the, quote, best estimates of viability. And I think the biggest thing here is we can talk about that or think about that. The reality is, in any particular situation, we often won't know how long the syringe has been there, so how long is it is the, quote, blood or virus outside of the body. Thanks for your question. Last case, as we try to wrap up here and just move on to some other questions or issues. A 6-year-old bites a schoolmate known to the principal and the school nurse as HIV positive. That means that the child who was bitten is HIV positive. The bite occurs through clothing. It's unknown if the skin of the HIV positive child is broken. In this case, post-exposure prophylaxis probably should not be recommended. You might ask the parents to contact the school and principal and nurse to confirm, in fact, that there was no broken skin and no blood additionally. And then potentially one might offer their services to the to either child and or either family, at least to help them move forward after this event. Do you see the cases like this at CPT, or because it's not a legal issue, that you actually don't see this?
Yeah, we wouldn't see this case.
Mm-hmm.
We had a case of, an autistic child that was HIV positive bit the teacher, and actually one of her tooth, was in the skin of the teacher. So we had to put the teacher on prophylaxis.
Mm-hmm.
And in that case, Sania, did the teacher know of the student's HIV status?
No. And because at that time the teacher knew that the patient was positive, and that's why she had to be on prophylaxis. They did not want the child in the school, and the mom was very upset with us. And actually, we did not tell the teacher, but the emergency room told the teacher when she came to our emergency room.
And
So
see, in this case 6 scenario, the principal and the school nurse knew of the one student's HIV status, but there wouldn't be a way that the classmate or even the classroom teacher should know that information. So I would suspect in this case the nurse, if she had been informed of the potential trauma to the student, how would she communicate, or she actually could not communicate to the family of the biter as to the risk that the biter might have.
That's true. In the actual scenario, the nurse and principal approached the child who was bitten with the HIV to just talk to the parents about that event so that they, one, knew it happened, meaning that their child was bitten, but also to address that issue and to clarify that, at least to be able to then also not have that be as much of an issue for the, quote, biting child, and then simply focus on, okay, why did the bite occur and how are we going to manage this in school?
Right.
So yeah, it can get pretty complicated pretty quickly. I want to finish up here, and in the last few minutes allow people any questions. I put here just summary of what we've said before, pretty obviously the decision making for PEP, and then when it's not recommended, so that you can review that. And then I wanted us to at least look at some issues that I've thought of, but I wanted to hear from anybody. Are there other issues or concerns that you all have about the use of post-exposure prophylaxis and considerations for the state of Florida and how we all practice that maybe we should be addressing or recognizing? So you can see here I put down a question about testing, getting it and having it be paid. Are we doing the same thing in different situations or locales? Could we move forward with a 7-day starter pack of PEP in Florida? Do we actually have a network of experts in pediatric and adolescent HIV care or NPEP for consultation? I know that both Dr. Friedman and Ms. Mahmoudi at their respective sites are certainly the experts that many individuals consult and call. And but the question is you know, does every place, each emergency room and or CPT team or program have someone who they utilize as their expert? And then finally, what other resources does anybody think we need to be focusing on in terms of providing appropriate PEP? So comments, questions, thoughts about any of those?
Is there a way to write for a grant state to have, you know, a starter kit available at child protection team, you know, centers around the state?
It's an interesting thought. I'm not sure Dr. Alexander probably knows more of those opportunities. What it makes me think of, Sini, is you know, could we approach the drug companies and the Florida Department of Health to facilitate with that, particularly in scenarios where you know, now with ADAPT and other scenarios, we can FedEx medications pretty quickly. And so whether you had a set pharmacy that was available to do this for any CPT place or any ER, and then all you had to do was call and get that mailed out so that the person could start that within the next 12 to 24 hours. So that might be a possibility. Other thoughts?
You know, it seems like, you know, following up with that this is really a good thing maybe with the Department of Health to, you know, address these issues in terms of what would be a model in terms of how we might do things here in the state. Obviously, we want the state to feel comfortable they have the answers to this so that they could, you know, so if we came up and said, well, here's a procedure that we want to do that's standardized across the state, we'd hope they would fund it because obviously it's something we want to do continuously if it's a good idea. And that means then government would have to be the funder.
Actually sounds like a good idea to me. We have at least two large groups, the Florida Caribbean AATC and the statewide CPT program that certainly could approach the DOH about this. So that makes great sense to me.
So it sounds like we've got ourselves something to do now, in addition to what we've been doing.
And the AATC medical director works in the Department of Health as well.